So again, good afternoon, good morning, everyone. Thanks so much for joining. Now that we have that housekeeping out of the way, we're really excited to get started today. We're really grateful that today we have Colin Case with us from the Radiation Injury Treatment Network. Colin is the program director for the RITN. I'm grateful to be with you today. I'm David Griesman. I'm the associate director of the Center for Disaster Medicine at Mass General, and on the RDHRS team and the vice president of emergency preparedness and continuity for the Mass General Brigham system. Really happy to be with you today. It's going to be a great session. We're excited to have Colin and to get into the conversation. Next slide, please. So a few additional housekeeping items. We will make the recording and slides for today's webinar available to all of you at our website, which is listed there. Please go ahead and mute your microphone. I've actually done that for anybody who's not presenting already, so nothing to worry about for those. We'd like these sessions to be as interactive as possible, so please do enter your questions into the Q&A section, and at the end of this, we will have sufficient time to make sure that we're able to ask Colin questions and to interact with each other this process. And then we just ask that if you're not already, please consider following the Region 1 Regional Disaster Health Response System on social media, and our Twitter handle is listed at the bottom. I want to just pause and acknowledge our partners. So this webinar is presented by the Regional Emerging Special Pathogens Treatment Center, the RESPECT, for Region 1, and the Region 1 Regional Disaster Health Response System. And as most of you know, both of these programs are funded by ASPR, the Administration for Strategic Preparedness and Response, with the U.S. Department of Health and Human Services. And as always, we're very grateful for ASPR's support and collaboration with us. This is our standard disclosure slide. Again, we have nothing to disclose. None of our speakers have anything to disclose for this session. Okay, so I've already done introductions. We're going to hear a lot more from Colin as we get into the content of today's session. Again, really just encourage participation, questions and answers in the Zoom function there, and we will have time to review those at the end of Colin's remarks. Learning objectives for today, pretty straightforward. So we want to make sure that at the end of the session, everybody who's joining is able to identify and describe the hallmarks and treatment needs of patients with acute radiation syndrome. That participants will be able to describe the RITN and its role following a radiological incident, and that participants will be able to integrate the information from the session into facility planning for care and treatment of radiation injured patients. Okay, and with that, I am going to hand the floor over to Colin. Colin, again, thanks so much for being here. We're really grateful for your time and expertise. We'll just give Colin 1 second as he pulls his slides up.
Yeah, thank you very much. Is my screen showing okay?
Yes.
All right. Thank you for that introduction. Thank you, everyone, for inviting me to present to you today. A little bit about RITN, a little bit about some resources that are available, and a little bit about acute radiation syndrome. So hopefully you'll find this not terrifying, but interesting and informative, which is our objective. So as mentioned, we're going to talk a little bit about each of these. The resources I'll go through pretty quickly at the end because I don't want to dive too deep into each of them, but you'll have links that are available to look at any of those more in depth afterwards. If you're not familiar with acute radiation syndrome, it's a result of getting a high dose of radiation to a biological entity. So human, if you get a dose of radiation, you potentially get acute radiation syndrome. And to kind of level set, there's actually more than 3 types of ionizing radiation, but the 3 that we'll focus here is alpha, beta, and gamma. And this may all be a blinding flash of the obvious that you all are well aware of, but alpha gets stopped by paper, beta gets stopped by skin, and gamma, it takes lead or concrete to stop it. So gamma is what X-rays are made of. They're deep penetrating radiation that can go through lots of material. So if there's a radiological mass casualty incident with an improvised nuclear device, you're going to have all of these. Plus, you'll have neutron radiation, which we won't get into. But the one that is the most damaging is the gamma radiation. So those gamma rays are the ones that are going to penetrate, potentially cause acute radiation syndrome. If you ingest alpha particles, you can get all sorts of complications as well. but that's a less likely hazard in the scenario that we're concerned with. And I'll probably talk way too much about that later as well. There's all sorts of different injuries that can come from the detonation of an improvised nuclear device. So you're going to have blast injuries, burn. You're could have flash blindness from the detonation, which, kind of, if you're as old as I or older, you may recall, duck and cover drills, where the flash is as soon as you see that, you want to duck and cover. Well, if this were to happen in modern metropolitan area, you're going to have potentially thousands of people driving, upwards of 50 miles an hour or faster on thoroughfares that are going to immediately get blinded and slam on their brakes, swerve, who knows what. So you're going to have all sorts of potential other, trauma that could result from the detonation. And then there's always mental health is a concern, right? The worried well, the walking wounded, whatever you want to call them, that are going to be concerned about their potential exposure to radiation. During the Fukushima disaster, there were over, I think, 960 calls to poison control centers in the United States by people in the United States that thought that they got exposed to radiation. So while in the United States, so they were not in Japan and got exposed and came home. These were people that were in the United States and were worried about, that they were developing signs of, radiation sickness in the United States after that accident. So, and there was no significant exposure to anyone in the United States while in the United States. So, so the fear of radiation is massive. And the misunderstandings behind radiation, or lack of understanding is also pretty significant. With the injuries that I'm going to focus on here today and that are the most concerning to the radiation injury treatment network is the basic radiation injuries, so acute radiation syndrome, and then combined injuries. And combined is where you have radiation exposure and trauma. And these are exponentially more severe and catastrophic. So many people could survive I'll put the levels on a slide later. I have them later, but many people can survive a significant dose of radiation with some, general supportive care to maintain fluids, antibiotics, and antifungals to stave off infections. But if they have even just a minor third-degree burn on 10 to 15% of their body, that now becomes fatal. So it exponentially increases the risk from those combined injuries. And then the image on the right is from, if anyone watched HBO's Chernobyl a few years ago, that was one of the firefighters in there. And, someone that would be this severely injured in a mass casualty incident would be expectant. So it's not what you would be expected to be seen in a hospital. It may show up at a hospital, but they should be triaged out as expectant, unfortunately. They're going to be overwhelmed with the number of casualties and patients that are going to need care, and trying to, throw the kitchen sink and everything else at one person versus doing the greater good for a benefit of a larger population is going to be one of the tough decisions that's going to have to be made. So as I mentioned, radiation injury is acute. It results in acute radiation syndrome with significant enough dose. There's various types of acute radiation syndrome, and these are based on the level of dose. The lowest dose causes bone marrow failure. Then it goes into cutaneous injury, gastrointestinal, cardiovascular, and then the central nervous system. So as the dose gets higher, you go kind of from the left to the right in what gets impacted. And once you start getting kind of into the GI syndrome, it starts to become pretty lethal. It's enough of an exposure that the chances of somebody surviving are very unlikely. Once their gut, they lose the gut starts to get destroyed and fall apart. They lose that barrier from all of the microbes that are inside the body, and they likely are going to succumb to those. So that a significant dose is going to be life-threatening. It's going to result in severe acute radiation syndrome. And even, talking, bone marrow is on the lower end. You're still talking the equivalent of like 200 chest X-rays So it's a significant dose is when we're talking in a mass casualty incident with rad nuke scenario. It's still a significant dose. And these are, so if somebody's standing behind a concrete pillar when a detonation happens, they're likely going to get a lot of shielding from that, or maybe they're lucky enough that they just happen to have a lead vest. Maybe they're working in a cath lab somewhere and they got their vest on, and on break they kept their lead on and went over by a window. If someone has some kind of shielding like of that, it's going to spare a lot of their marrow. So if a good portion of their marrow is spared, they likely will be able to self-recover. And we have some physicians that'll say even, just being able to save, the marrow that's in a pinky finger is enough to be able to reconstitute their immune system or their full marrow production. But that's, a few of our physicians feel that that's, you don't need a lot to be able to help build them back from the death's door. And the reason for that is that the marrow is what creates all of your blood cells that results in your immune system. And then without that marrow, without those hematopoietic stem cells, you're not going to be able to create an immune system that's going to protect you from all of the vectors that are out there. And there really are limited treatment options. So you're talking about, as I mentioned before, some intensive supportive care. So if you can get somebody into a hospital, into HEPA filtration to keep them protected, give them antibiotics, antifungals, lots of fluids, these things, the vast majority of patients will be able to recover with that care. And then some will need to actually go to a marrow transplant. So there's, as I mentioned, you get the kind of the levels of exposure. So you get going from that bone marrow to cutaneous to GI, and it all doesn't happen at once as someone gets that significant exposure, that severe acute radiation syndrome. They've got different phases of the disease. So you've got that initial effects, that the prodromal, and then latent effects that are going to come on later. And I've got a chart here in a few slides that talks about kind of the timeline for that. But you get that initial effect where if someone gets a significant dose, they're going to feel nauseous, possibly have diarrhea and other symptoms that nausea, vomiting, anorexia that will show up, and then they'll start to feel better as their marrow starts to be released. The other marrow that's in their bones starts to be released to kind of reconstitute or try and make up. But if a good portion of their marrow has been killed off, then they're not going to have enough to keep that going to fully restore their hematopoietic system. So then what happens is they end up with the latent effects. So weeks to a month later, potentially, all of a sudden they're not going to be able to keep that up, and that's when they're going to really hit bottom, and that's kind of the real critical time when then it can become a lethal effect. So there are some medical countermeasures that are in the Strategic National Stockpile. I've got them listed there. But so you need to know what's in there, and these are held in vendor-managed inventory. So we're not talking about a few thousand doses. We're talking about hundreds of thousands of doses that are potentially available at the manufacturer's storage facilities. So they've, the idea behind vendor-managed inventory is that they add a bubble, right? So you've got your normal logistics supply. If they need to have 1 million doses a month for worldwide supply, they're adding, an extra warehouse to add 200,000 doses or whatever those number are to make sure that they always have that additional amount available, and that is already paid for by the government. And then they're given funds to maintain that so that they keep that additional amount on hand and make it quickly available to distribute during the following an incident. Unfortunately, there is no drug that can be taken prior to exposure to ionizing radiation to protect you. So there's no prophylaxis medical countermeasure. The only thing you can really do to protect you is either get distance or get some kind of shielding in between you and the exposure. And since these 4 items are these are FDA approved, and that's why they're in the SNS, there's no need for emergency use authorization. There are some, if you look at the inserts for these, you might notice that the doses are much higher than what is typically given, and that was based on the animal rule. So some physicians may want to go off label to use the dosing that they're typically used to. So the physicians in our ITN that are bone marrow transplant physicians, typically this is double what they're usually giving their patients. So I think most of them have said that they would probably go off label because of the to save on that critical resource during a disaster. All right, so that's kind of the basis of a little bit kind of high level on acute radiation syndrome and a little bit about the radiation background. And as I mentioned, RITN, we are a group of hospitals across the nation that are preparing for that mass casualty incident. What's unique about our scenario is that we're looking at a distant incident or the response to a distant incident. So I live in the Twin Cities of Minnesota, so Minneapolis, St. Paul. I'm not thinking about what happens if a bomb is detonated in Minneapolis, St. Paul. I'm thinking about what happens if one is detonated in Des Moines or Chicago or Dallas. And those patients need to be evacuated through the National Disaster Medical System to a distant care facility because those local areas are overwhelmed with the response. So in your instance, is New York, Philadelphia, or Pittsburgh, have they been attacked? Detroit, have they been attacked? And are they trying to evacuate patients to the Boston area to get them the care that they need because they're overwhelmed in those locations? Is really what is kind of the scenario that we're looking for. Our funding comes from the Office of Naval Research to ensure that we can keep all of these hospitals interested in doing annual training and exercises and maintaining their activities that are related to RITN. And so as I already mentioned, we've already kind of gone over the details there, but it's really most of these hospitals are have a bone marrow transplant unit or a very strong hematology oncology staff that are working with patients every day that have been exposed to ionizing radiation, and they've been exposed on purpose. So if someone has a leukemia or some other kind of blood cancer, one of those treatments is to give a bone marrow transplant. And before they give that bone marrow transplant, they give them a high dose radiation, a uniform dose across their entire body to eliminate their existing marrow before infusing that donor's marrow. You can also do chemotherapy to kill off their marrow. So there's another path that can happen, which actually is akin to a mustard agent incident. So if you've just finished doing or you're finishing up doing your radiation annex update this year for ASPR, next year it's a chemical incident. So you might be able to piggyback off of that if you do a mustard agent incident and tie into involving your bone marrow or cancer centers in the incident response. So since this is done typically before they infuse that donor's marrow, we've got staff at each of these facilities that are working with patients every day that have kind of mimic acute radiation syndrome. They have the same complications that follow being exposed to radiation. So they know what to do. Most of them, when you tell them that they may be involved in a disaster, they do a double take and say, "Wait, what?" Because they've never been involved in any kind of disaster. So you have a large fire or accident, they're not the ones that are getting called down to the ED or out to the site to help. They're usually watching it on the TV. So they usually need to be give them a minute to let them absorb it and understand that they're not going to be showing up to the disaster site, that these are going to be patients that have been triaged and surveyed for radiological contamination, decontaminated, transported by the National Disaster Medical System to that distant hospital, and then they're going to be coming in with potentially severe acute radiation syndrome for care. So as I mentioned, we're funded by the Office of Naval Research. The National Marrow Donor Program, or Be the Match, who's my employer, has the grant with the Office of Naval Research to improve outcomes from transplantation therapy. And I've got a very small team, including myself. We have about 2.25 staff that work on this. So 3 people, but not all of our time goes towards RITN. My second hat is business continuity for our organization. So that's about half of my time. And then I've got one person that works on exercises for our disaster recovery program, as well as the exercises for RITN. If you're interested or curious about what hospitals are in the Northeast or anywhere in the United States, you can go to ritn.net/map and see all the hospitals. It's an interactive map where you click on the dot. It'll show you the list of hospitals, whether they're adult or pediatric facilities, and what city they're located in. And this is a short list of who's kind of in your immediate surrounding. But as I already mentioned, you can go out, get into New York. We have quite a few. Get down to, keep going, west, you're going to hit Pittsburgh, Cincinnati, down into New Jersey, Maryland, and Virginia are the next kind of states that have a significant number of facilities in the Northeast of the United States. We've been around since 2006 and working diligently to help each of these hospitals get involved. And again, when we first started, as we started working with these BMT physicians and staff, most of them had no experience with any kind of disasters. So we focused on making sure that they got integrated with their emergency preparedness teams, emergency management, whatever the title is at your institution. And then each year we require them to participate in an RITN created tabletop exercise and do some training. So we have online training, and then we have all sorts of other options where if they end up going out to CTOS in Nevada, that training can count too. But we've had a lot of people take our online training. We have a bed reporting system to track the number of doses of those key medical countermeasures, what's on hand, since these are typically used during the treatment for cancer patients, as well as the number of adult pediatric beds that are available today and how many will be available in 24 hours. And during an actual incident, our intent is to have these updated daily. We share these through a portal directly with ASPR and to their SEOC so that they can be aware of what beds are available at our facilities for ARS patients. And if I didn't say it already, we have 74 hospitals currently in our network. So as I mentioned, we're really looking at a distant incident. So it doesn't mean that there isn't some applicability to a lot of the efforts and understanding and education and training and preparedness for a local disaster. But really our focus is to make sure that we've got hospitals that are potentially 500 miles or more away from an incident to receive those patients through the National Disaster Medical System. And I can't stress that enough is, as I mentioned, 2.25 people. We do not have aircraft. We do not have ambulances or buses that we can transport people. This is all being coordinated by the National Disaster Medical System to get them out to where they need to be. And then the NDMS is the backstop for the payment for their care as well. So we're talking about something that's going to be devastating. It's not going to be pretty. It's going to severely impact that local community, and but it's not, it's not a futile effort. So it's not the same as, again, if you're as old as me, you remember duck and cover drills, worrying about a megaton device that would literally wipe out a large metropolitan area. But when talking about a terrorist device, the current word on the street from Health and Human Services is that 2 10K devices, this is the current scenario, being detonated in separate cities across the disparate in the United States, so distant cities, whether that's Houston and Los Angeles or 2 other cities, to try and make as much of an impact as possible. Or for a while, when North Korea was really rattling the cage 3-4 years ago, there was talk about a 200 kiloton device that was their current at the time size of bomb that they had that they were working on. But if we're talking about a 10 kiloton device, which is in the national planning scenarios from a Homeland Security, you're still, even though it's, again, that image is devastating and can be scary to people. When you boil it down and look at the damage, the severe damage where everything is going to be leveled is about a half-mile radius. And then when you get out to about a 3-mile radius, that's where you're going to have, windows that are broken, or doors knocked down from the overpressure of the blast. But then beyond that 3 miles is no, significant damage to mention. However, what needs to be taken into consideration as well is the fallout. So you're going to have a lot of trauma and injury inside those areas. And when you get in close inside that kind of that moderate zone, if it's in a major metropolitan area like New York, you're going to have feet, potentially 10 to 15 feet of rubble in the roadway. So when the blast, it will be knocking down the facades and the windows off of skyscrapers, and that's all going to go into that that roadway that's below. So it's going to be pretty much impassable. So you're going to have you may have a lot of injured people in that area, but it's going to be hard to get to them. But that's, again, a separate scenario as our focus is on the distant reception for them. And as I mentioned, you've got the potential for fallout that's going to need to be considered. So, fallout has always been talked about, and where it's has become more and more concerned in planning scenarios is that if people are not going to shelter in place and they're going to be outside, or they're going to try to escape, they're going to try to walk or drive, thinking that they can go through this the purple area is a dangerous fallout zone. An hour or two exposure in that area is enough to give them an acute radiation injury. So we really want people to shelter in place. And then that's the good thing, is that sheltering in place protects you, or can protect you, and that fallout decays quickly is the other great thing about it. So the image on the right kind of shows, we've got these numbers in those buildings. The higher the number, the better the protection. So if you're looking at a regular, single family home on the left, if you go into the basement, you get a 30 level protection. That doesn't mean it's 1/30th, but it's a significant protection from the radiation. A vehicle is 0, I believe. It's 1 or 0. It's almost nothing. So getting in a vehicle is not going to help. Where if you get on the far right, and you're talking in a multi-story concrete apartment building or office building, you're talking about 1,700, upwards of 1,700 being the protective factor. So getting people to get inside and stay inside and stay tuned is very important to help them survive. And again, it decays quickly. So that's the great thing about this, is that if we can get people to get inside and stay inside for a while, that it's going to protect them enough that then you can walk out and not have to worry about it. So these 3 images here on the slide show kind of how quickly the dangerous fallout zone shrinks. So the light purple is the full area at detonation, and then within an hour it's shrunk down. It was at maybe a third, and at 2 hours you're talking down to maybe 2/3 is shrunk, and this is based on the 7/10 rule, which means that every 7-fold increase in time, you decrease the amount of radiation 10-fold. So at 7 hours, you have 1/10 of the radiation. So if you can get people to shelter in place for 2 days, 49 hours, you're looking at having less than 1% of that dangerous fallout left to cause injury. So there's still going to be some radiation. So you see on the right image, where you'd still have that light purple kind of outline. There's still going to be some, but that's enough. That's low enough of a hazard that it's not going to cause any significant injury to anyone that's walking out or driving out through that. And earlier I had mentioned, the alpha particles. You don't really worry about that because this isn't inhalation hazard. So it's not like a nuclear power plant where you've got burning material that has smoke that people can inhale, where you've got radioactive nuclei in the smoke that they can inhale. These particles are the size of grains of sand. So unless somebody is looking up, opening their mouth and purposely trying to ingest or inhale these particles, they're not going to be getting them internally. What's on there, lands on you, you can, pretty easily brush off. By removing clothing, you're going to remove almost 90% of the potential contamination someone could have on them. If you can remove their clothing and wash off their hair and head and any exposed skin, you can get 99% of the contamination off of them very easily. Again, so the National Disaster Medical System is the method of movement of these patients to get them to where they can get that definitive care that they would need. So where they can get someone that understands acute radiation syndrome and can give them the either the medical countermeasures or other supportive care to help them bridge the gap while their immune system is recovering. And it's the end result is that usually NDMS isn't looking to move people. Their CONOPS actually I think says they'll move, I think it's 200 miles, and then they won't once in the receiving city, they're not going to move anyone more than 75 miles away from the federal coordinating center, that airhead that they receive them at. However, if we're talking about a nuclear detonation where you've got hundreds of thousands of casualties, those local cities, metropolitan areas are going to fill up pretty quickly, not only from any evacuation through NDMS, but also from people that are self-evacuating and then presenting on in those other cities. So you're probably going to have people that are going to be getting moved to much further locations than what is the standard for NDMS. That's Cullen's opinion. It's not an official statement. It's not official policy. The RTR concept is what ASPR uses for their radiological triage, transport, and treatment. And they, without saying it, kind of align towards it's probably going to be further away than the adjacent states to receive enough or to have enough capacity to care for everybody. So as I mentioned earlier, you've got kind of that hematopoietic syndrome, and then the cutaneous and GI, cardiovascular, and then their neurovascular syndromes. That's on the left image there, where it goes from green to red. So the higher the dose, the worse the case. And you can see in the far left side of that, it goes from 0 to 12 and above, and that's the dose in gray. GY is the gray. So again, about 2 gray is equivalent to almost 200 chest X-rays. So it's a significant dose, but it's a survivable dose. So at about 2 gray, like a half a gray to 1 gray, is when people start seeing those signs or symptoms of nausea, vomiting, and diarrhea. And at that level, between there and 2 to 3 gray, people are almost 100% survivable with just making sure that they've got nutrients, they're eating and getting fluids and getting rest. When you start getting up above that, now you're getting an LD 50-60, so that's about a lethal dose for 50% of the people within 60 days or 2 months. But you can move that bar up to the 6 gray level if you're able to give them cytokines, which is the medical countermeasures that are in the SNS. So the filgrastim, pegfilgrastim, if you can give that to the patients, that would move that bar up to from 3 gray up to 6 gray. So it can make a significant impact on those that are exposed to radiation. And then, as I mentioned, also, you got that prodromal and the latent phase. So if you look at the red line on the right chart, where you have kind of that initial peak and dip, that's where people have that initial kind of exposure where they're the first week or so where they're feeling horrible. Then all of a sudden they feel great. They start to feel a lot better. And then that second dip is around the 3-week time frame there where the arrow is, where that's kind of, if they don't get that intensive supportive care there, then they could potentially die. And that's, the red line there is that 2 to 5 grays. So that's that LD50 group there. So some will survive, but if they don't have that intensive supportive care, with antibiotics, antifungals, and ideally cytokines to help bridge that gap, they would not survive or will not survive. We've got another rule for you to remember, and that's 2x4 rule. Nick Daniak, who used to be at REACS, kind of got this one popularized a few years ago. If somebody is vomiting, and this is like severe, unstoppable, continuous vomiting, it's not sympathetic vomiting where someone sees someone throw up, they throw up. Ideally, then they move away from that person and then they feel better. But this is where they're just uncontrollable. It keeps on happening. If they're doing that at 2 hours, then they likely got a 4-gray dose. It's kind of a rule of thumb. And if they're doing it at 4 hours, then they probably got a 2-gray dose. So if 4 hours after the incident, people started throwing up profusely and repetitively, they probably got a 2-gray dose, and that's eminently survivable. And then if it's at 2 hours of throwing up, that's where you really need to worry about. So if they're getting it 2 hours or less, they've got a significant dose that's potentially lethal. And if it's less than 2 hours, you start getting into, if it's within an hour or 30 minutes, you start getting up to the 6 to 8 gray range, which is probably expectant if they're not transported quickly to a place to get definitive care. So the scenario, as I mentioned earlier, it's pretty complicated. So not only do you have all those different types of injuries and combined injuries, and the potential outcomes from that that are decrease with the combined injuries, but it's hard to tell what dose they receive. So the 2x4 rule hopefully help maybe give you a little bit of idea. Otherwise, you have to take blood counts, and those blood counts need to be serial CBC diffs to track and see what their blood counts are doing, which is that right image there is blood counts, the neutrophils. So you'd be able to track and see if they're getting, if they really did get a significant dose. One public open source document that ASPR published in 2011 has a number of casualties, and this is based on a detonation. They don't say it's New York City, but it's kind of obvious based on the description, and that it's would be New York City. If that were to happen, you'd have over 500,000 casualties. And if you break down those casualties, which they do in the document, you can see that about 60% would have trauma. So that might be people that were driving that got flash blindness and got in an accident, or other people where they windows blew out in their where they were, and they got glass, either glass injuries on their body or potentially even in their eyes. And then you've got 15% would have just mild acute radiation syndrome. So those would likely be ones that would be seen and then told that they can be discharged to watch for signs and symptoms of acute radiation syndrome, or possibly be in some kind of field hospital where they're watched to see how they progress. 8% would be the black that are actually have severe ARS that would be expectant. So those are 6 gray and above exposures that would be likely expectant. And then 7% would have combined injuries. So that would be the trauma and radiation that would need to be stabilized first to take care of the trauma. And then if there still is time and they're still alive, get them to a place where they can get cared for the acute radiation syndrome part of their injuries. And about 10% would have radiation exposure only, and this would be in the moderate to severe range. So these would be kind of the perfect patients to send to a written center if you can triage out this 10%. That would be ideal to be cared for. And even when you break down that 10% further, that's the right side of the screen here. Only about 1% would be likely candidates for a marrow transplant. We need about a third of them in inpatient care to give them isolation and ideally a HEPA filtration room and making sure that they're getting cytokines and the other supportive care. But even within that 10%, you still have about 70% that are going to be in that lower end, down around the 2 to 4 gray that, with minor care, they might survive. Some of them would be or would recover, not survive. Then there would be some that might need a little bit of extra care. They're going to need to be brought in for inpatient care. And there might be some of those that actually recover quickly and can be discharged. But if you break down that 10%, you really probably need to have about a third that would be that really need to be in a bed in a hospital. And 2/3 approximately can be cared for outpatient in a hotel or in a field hospital or wherever you're able to care for them. And if you can, again, when you're doing that triage, that initial triage to try and get the 10% that have that moderate to severe radiation exposure, you can figure out the ones that have that moderate, that 70% that are on the lower end. That's even better to not triage them to be moved, but to just get them to somewhere closer to the disaster site, instead of moving them further away and using those resources that are going to be pretty limited during the time following a disaster of this scale and magnitude. So there's a lot of information. And now I'm going to kind of talk through pretty quickly on the resources, and then we'll have some time for Q&A, I think. Again, all of these are just to show you there's a lot of stuff that's already been done so that you don't have to recreate the wheel, build off of the backs of those that have come before you. There's a number of plans that the feds have created, and RITN are involved in all of these that are on the screen, from the White House planning guidance to FEMA's Rad Nuke incident annex, to a number that ASPR has created that are on their website to review. As a kind of a summary slide of some of the key resources on our website, we've got treatment orders, triage guidelines, we've got referral guidelines. So if you want to have an affiliate hospital, you want to tell them what to look for acute radiation syndrome, these are referral guidelines. You can put in your contact information. It tells them what signs, symptoms, and blood counts to be looking for to reach out for someone to care for them for acute radiation syndrome. We've got all of our exercise materials, online training materials. We have a YouTube channel and it's actually been shortened now. That link can be youtube.com/@RITN2006. Since we submitted the slides a month ago or so, we've updated that link. The link on the screen still works though. And then there's a number of apps. If you appreciate apps, REACTS, the Radiation Emergency Assistance Center and Training Site, has an app, and they have a number of our resources incorporated into their app. And then REM, the Radiation Emergency Medical Management website, which is a ASPR website, has a ton of fantastic information, and it ranges from first responder information, on contamination, decontamination, radiological survey, to very detailed medical management and biodosimetry calculators that they have on their website. So I encourage you to look at both of those apps. And then the Armed Forces Radiobiology and Research Institute also has an app. It's the mobile FRAT, the First Responder Assessment Triage Tool is what the FRAT stands for, the acronym. You have to go to their website and ask for access to it. So to, again, kind of quick shots with the websites that these are at, we have treatment guidelines on our website we've had in place for a number of years at ritn.net/treatment. The referral guidelines that I had mentioned would be given to an adjacent or hospital nearby that could tell them what signs and symptoms to be looking for before reaching out for assistance with acute radiation syndrome. And we're working with the American College of Toxicologists to put something very similar to this into poison control centers across the nation to help with triage if that were following a radiological disaster of this magnitude. Cytokine triage guidelines. Again, these are the drugs that are in the Strategic National Stockpile. These three are the cytokines, and then the fourth one is a little bit different drug, so it's got different applicability. So it's not included in this document. And we have this on our website in multiple sizes. So you get a PDF that's 4x6, so it's almost a pocket card, or small. You can get an 8.5 by 11 version, or you can get a poster size if you wanted to put it up on a wall somewhere. And those are all free to download and use as you see. And all these resources are free. We've got exercises that we've been running again since 2006. Many of these are tabletop exercises, but we also have a number of functional and full-scale exercises, to the point if you are doing a full-scale exercise. We did one with Dana-Farber a few years ago now. It might be even 2010 or 12 already, where they had actual patients out at the airport and had a number of triage cards for patients to be, exercise the medical personnel that were involved with triaging those patients that were on the triage cards. As I mentioned, so these are some pictures from some of the exercises that we've helped fund and coordinate. We've been very fortunate to partner with the FCCs to get involved when they're actually moving aircraft. We created a functional exercise toolkit for the last couple of years for the radiation requirement from ASPR, from the HPP program, to update the Healthcare Coalition program to update the RAD annex. So this is a full exercise kit that has a video that goes with it to help walk through. We're working on one similar to this for a chemical agent for next year to help with that requirement from the program as well. Again, this is on our website at written.net/exercises HCC functional. You can see the link there. Again, more on training. We've got medical grand rounds, full training slide set that's available to use. And this is in a PowerPoint format, so it can be modified to add training objectives or additional intro slides, like at the introduction to this presentation, to help train medical staff on the identification and care of patients with acute radiation syndrome. We have a number of online training assets as well. Kind of the key ones in here that would be very generic and used: basic radiation training, the non-medical radiation awareness, radiation safety communication, and initial care of patients. So all of these are online based. They're free. We do ask for a name and an email, and that's so that we can track who's taken the training and to give a training certificate at the end. But we don't use those emails for anything beyond that. As mentioned, we have a YouTube channel, and there, I guess I did get the correct updated YouTube channel link in the top right, so the @RITM 2006. We've got a number of videos on there. So there's a 15-minute kind of just-in-time training for healthcare providers on acute radiation syndrome on the bottom right. You have someone that's kind of new to radiation disasters. We've got a 3-series video set on the top that talks about kind of what to expect before the disaster, kind of planning before what happens as it's the initial phase, and then the following phases. And then we've got a bunch of videos from exercises that have been conducted in the past, as well as a very short 4-minute overview of RITN, the top left there, the RITN What You Need to Know video. I mentioned these a couple of apps that are available. So the REACTS app can be downloaded on the Google Play or Apple App Store for free, and many of our assets and resources are incorporated in that. The REM website, as I mentioned, is fantastic. They have our adult and pediatric medical orders on their website. We've collaborated with them since 2005. to make sure that we're in kind of lockstep on the care of acute radiation syndrome patients. And then we worked with the National Alliance for Radiation Readiness a few years ago to create 4 videos that are intended for really public health preparedness staff that are new to radiation disaster. So it's geared towards public health preparedness, but I think anyone who's new to radiation disaster response would benefit from taking a look at these short videos. They're 6 to 8 minutes in length each, so they're not very long, and they cover a lot of good information. All right, and then kind of closing. So just remember the distant response is our scenario, and that we're integrating with the National Disaster Medical System. So we're not moving any patients, NDMSs, but once they get to these cancer centers, that's where that acute radiation syndrome can be cared for by doctors and nurses and medical staff that are working with these kind of patients every day as part of their care for blood-borne cancers. Try to remember, if you want or if you can, those 2 rules, so that 2x4 rule and the 7/10s rule. These are great resources to help keep in mind, how quickly that dangerous fallout will decay, and how to kind of give a really rough estimate of their exposure. So, especially when you're close in right after the disaster, you're not going to have time to get your radiation safety officer or a radiation oncologist to try and figure out what their dose was. You're not going to be able to take enough blood samples to kind of figure out where they're at, but this can help you get a real rough guess at where they're at for triage. And as I mentioned, the distance is not going to preclude involvement. It's communities, hundreds of miles away are likely going to be end up getting patients from this disaster, whether they're being moved by NDMS or they're being self-evacuated. And these injuries are going to be really complicated. That's really kind of the rest of the points in there is that, when someone has just radiation exposure, it's going to be hard to tell sometimes what that level of exposure is. When they start adding in the combined injuries, that just makes it exponentially more complex. So it's some really tough decisions are going to have to be made on triage, and then you're going to need to make sure that you've got a serial triage. So they triage out those that you think are expectant, and then make sure that they don't just get forgotten, because if you look at them again later, they might be able to be cared for and survive. Couldn't be here without any of the partners that have helped us get to where we're at. And I think I'll take it back to you, Jack or Dave, to take over and put the question slide up with 5 minutes to spare.
Yes, plenty of time for questions. And again, people should feel free to enter them in the Q&A session. Colin, thanks so much for a great presentation, really an exceptional level of detail. I think that you do a wonderful job of explaining radiation injury to people who know nothing about it and to people who have heard about it but need a little bit of a reminder. So kudos on a really nice presentation. One quick question from me, and looks like we have one in the chat as well, but I'm curious, you mentioned, and I think most of the people on the webinar know that there are several RITN centers in Region 1 here in New England. I'm just curious what best practices you would call out for RITN centers, the way they've been able to integrate RITN operations and prepare into their normal operations as part of their preparedness efforts.
Yeah, no, that's a great question. Thanks, Dave. The biggest, probably best practice we've seen is once you get emergency management or business continuity, depending on what it's called at your institution, involved. So we had early on a lot of hospitals where they were really trying to figure out how to get tied into the local hospital coalition and into the disaster response to make sure that patients that arrive don't end up sitting down in the ED, that they can be moved into the BMT unit for care if they have acute radiation syndrome. And that's been one of the biggest kind of best practices, making sure that you got your emergency management, your safety committee, whatever you call it, engaged with the plan And then it's, the annual kind of tasks that we give really, we think, bring everyone together in that tabletop exercise to kind of talk about what the scenarios and how they would respond. And then since we do these virtually now, the last I don't know, 7 or 8 years, we're seeing where, Mass General might be on the call with Emory, and Emory's doing something different, and be like, wait a minute, hey, Sam, I'm going to talk to you afterwards. So you can tell me exactly, give me a copy of what you're doing. And we're finding you might have, some competitive nature within a city where, you're not really allowed to talk to that other hospital because, there's, they're not in not part of your network. But once you start getting farther enough away, you can really share some information that helps to make it exponentially, exponential improvements in what you're doing. So you're building off of their work, and then ideally they'll see something you're doing that's different, and take that and implement it.
Great point. The importance of collaboration. Definitely hear that. We do have a question that is on the screen. So, are there tools available to offer rapid just-in-time training for healthcare workers that might not normally work in hematology and oncology settings?
Yeah, so there are a few, and if you look on as I mentioned in our YouTube channel, we've got about a 15-minute video that we created in conjunction with Emory a number of years ago that goes over kind of all of the kind of soup to nuts about acute radiation syndrome for signs, symptoms, and care. We have also a couple of self-paced courses that give kind of basics of care to try and get medical professionals kind of up to date. And then we also have the grand rounds training. So as I mentioned, there is time, and if you're thinking, again, distant, right? So bomb goes off in New York, there's gonna be all sorts of chaos. You're gonna have potentially a few days before you're getting overwhelmed with patients that are coming up to, let's say, the Boston area through the National Disaster Medical System for care. A lot of those initial ones are going to be for trauma. So if you're telling your hematologists and oncologists and rad-onc teams to, hey, take a look at this, you can get somebody together to present the grand rounds training to that group of physicians, so they're better prepared for those that may have acute radiation syndrome. So you kind of you can watch the video in 15 minutes. That's the real just-in-time. And then if you've got, a day or two, you could pull together the medical grand rounds training and spend a little bit more in-depth time with those medical professionals.
Thanks, Colin. Really appreciate the detailed answers, and again, so grateful for your time, expertise, and for the presentation today. We are at time. An hour goes quickly. I want to thank Colin again, the RDHRS and RESPECT team for organizing this, and for all of our participants today. As a reminder, you have the information for continuing education credits from the beginning of the session, and this recording of this session and the slides will be available on the RDHRS website. So stay tuned for future information about webinars that are coming, and thanks very much, everyone, for joining today. Take care.
Thank you.